little bit of background. Taylor earned her PharmD at University of Pittsburgh. She was recruited by our colleague Sumi Abraham at the time, who was also at Pittsburgh and then came here. From the beginning of the time that I've known Taylor, she's always been really focused and very passionate about pharmacist work, the workload that they deal with, and the fatigue that ended up becoming her master's and dissertation topic. So I just want to say that I'm super proud of her. She's been a fantastic rockstar graduate student, and I'm so pleased that you came to watch our presentation. Thank you.
Thanks, Michelle. Okay. All right. Hello, everyone. Thanks for coming. Oh, look, we've got a couple more. Hello. Wow. Well, thank you all. Thanks for making the trip over here in person. Thanks to those who are here on Zoom. But thank you. Thanks for joining me for my dissertation talk this morning. So I'm sure you saw on the flyers and everything, the official title of my talk is Validating a Tool to Measure Pharmacist Fatigue, Implications for the Quadruple Aim. But I'd actually like to propose a slightly updated title that probably more accurately reflects what we're going to talk about in our short time today. And that's just very slight change. Pharmacist occupational fatigue, COVID-19 and beyond, implications for the quadruple aim. Before we want to jump in, I want to give you a brief roadmap of where we're going. So we'll talk about the background, the significance, what I mean when I say this word, occupational fatigue. We'll talk about our conceptual framework, our research question, and our methods, our results, and discussion. And then we'll round out with some time for open discussion at the end. For those on Zoom, feel free to put any questions or comments in the chat feature, and our fantastic moderator, Tyler, will make sure that I get to those as well. As a reminder, this is a very small snapshot of my entire dissertation, so please feel free to ask questions, find me later. I'd love nothing more than to talk about pharmacist fatigue for hours and hours, and on and on. And a lot of that is because of an experience that I had as a young pharmacy student here. You can see me when I was a little bit younger, had a little bit shorter hair. And I worked as a technician and a student intern at a chain pharmacy called Rite Aid. And during my 5 or so years there, I was able to float around to a bunch of different stores in the Western Pennsylvania region, work with different pharmacies, different technicians, take care of different patients, and I learned a lot. And one of the things that I made sure to do at the end of every shift was ask for one piece of advice from the pharmacist that was staffing. What recommendations would they have for me as a future pharmacist? One pharmacist told me not to flush the pharmacy keys down the bathroom toilet, which they had learned from experience. Another talked about the value of using the team and the ability to say no. And one pharmacist, who I won't forget, looked at me with a straight face and said, "Yeah, don't become a pharmacist. It's terrible." And that interaction stuck with me, obviously, 5 years later, and led me to ask a lot of questions. Why are some pharmacists so miserable and honestly hate their jobs? Why can there be some days where we can fill 500 prescriptions and it's really easy and feels like a breeze? And there are other days where 50 prescriptions feels like an absolute chore. Why do some pharmacies hit metrics and others can just barely stay afloat? And so these questions honestly fueled me throughout pharmacy school until my professors, Dr. Abraham, took notice and recommended that I consider graduate school to figure out some of the skills that I needed to answer these questions. I share this story because for me, and maybe for some of those either in the room or on Zoom, it's a really personal topic and relatable and hits home. And I'm excited to share what I found, as well as provide some recommendations for the future of pharmacy. One of the first key pieces on my journey was learning about the quadruple aim. So the quadruple aim calls out 4 key strategies that are crucial to optimizing patient care. First, there's providing quality patient care. That also means safe patient care. There's improving the patient experience and doing all of this while reducing costs to both the patients and to the healthcare system. Now, previously, these first 3 aims stood out on their own and were called, as I'm sure you can imagine, the triple aim. But this 4th aim, improving the work life for healthcare professionals, was introduced by the Institute for Healthcare Improvement in 2007 as a way to address the suffering that was found in the healthcare professionals who were trying to meet these other 3 goals. The quadruple aim recognized that healthcare professionals have to be taken care of first before any of these other aims can happen because of their integral role in providing care. And if they're not, mistakes will happen, the patient experience will decrease, and there will be increased costs. One facet of employee work life that's crucial to focus on, as I'm sure you can imagine, is occupational fatigue. So to put very simply, fatigue is your body's biological signal that it needs to rest. Throughout the presentation, I might shorten occupational fatigue to just fatigue, but I mean the same thing, this need for recuperative or restorative rest that occurs during, after, or is in any way related to the work that we do. And fatigue can be described in many ways. There's physical fatigue and mental fatigue, acute and chronic. There's also active fatigue, like the exhaustion that we feel after navigating through a bunch of traffic, or passive fatigue, like that feeling when you can't stay awake when you're driving on a straight, empty highway for long periods of time. It can be described as a general lack of energy or even sleepiness. Just as a quick note, sleepiness is one feeling that makes up fatigue, and sometimes it gets conflated, fatigue and sleepiness and tiredness. They're not exactly the same. Sleepiness is just kind of one small piece of the puzzle. And so it's also important to think about what's causing occupational fatigue. Why does it happen? One way that I like to think of it as a balance between our work demands, that's all the things that we have to do and the time that we have to do them in, and our capacity to do the work. That's all the resources, maybe the personal bandwidth, or our work within our organization. And fatigue often occurs when our work demands outweigh our capacity to do the work. We get these feelings of excessive workload and fatigue as a result. For example, maybe we have 75 prescriptions in our queue, 5 people waiting in the store for COVID tests, or drive-thrus backed up with more COVID tests than on any other day. It wouldn't be a problem. But today we didn't get enough sleep, we forgot our coffee, and we had 3 technicians call off all before 10 a.m. So you can see now that we've tipped the scale and that our work demands kind of outweigh our capacity. And occupational fatigue doesn't go without its risks. It's been studied in other professions like transportation, truck drivers and pilots, and heavy industry, in nurses and physicians. And in these healthcare professionals, occupational fatigue has been associated with negative outcomes for the employee, like reduced job satisfaction, increased risk for health problems and injuries, and even a greater likelihood of getting into car accidents on their drive home. Occupational fatigue has negative outcomes for their patients. There's decreased reaction time, increased diagnosis time, increased errors, and overall decreased experience. And finally, there's negative outcomes for the employer, such as meeting metrics, quality, and employee turnover. Not just limited to healthcare, but it's been estimated that workers with fatigue cost employers over $100 billion, that's a billion with a B, in health-related lost productive time a year. So we know that occupational fatigue in these other professions is bad, and we might be able to guess that occupational fatigue plays a role in our community pharmacists as well. And when I say community pharmacists, I mean those people that you typically associate with a typical retail pharmacy. Places like your national chains or your independents, where pharmacists literally have direct access to patients and their communities. And community pharmacists are crucial healthcare professionals in these areas. They've been touted as the most accessible healthcare professional, even in rural areas where patients may not have access to doctors' offices. During the COVID-19 pandemic, they've provided vaccines, they've been doing testing, they've been providing self-care recommendations. And they're doing all of this on top of their normal work of filling prescriptions. And even when they fill prescriptions, pharmacists are the last line of defense to make sure that no medication errors reach the patient, doing things like checking doses and allergies and making sure that the medication is appropriate. But community pharmacists work in really unique environments. They're kind of this odd mix of healthcare and non-healthcare retail settings. People don't make appointments to go pick up their prescriptions. There's usually a drive-through, which has been compared in a lot of times to fast food restaurants. There's information coming from everywhere. You have drop-off windows, pickup windows, drive-thrus, faxes, telephones, electronic prescriptions. And all of that makes it hard to predict and control your work. In fact, 3 out of 4 community pharmacists have reported their workload levels as high or excessively high. And let's not forget they're usually standing for their entire shifts. Until recently, pharmacists didn't get designated lunch breaks, so they would go 10 to 12 to 14-hour-long shifts standing, often without eating, and sometimes even without time to go to the bathroom. And so especially with COVID-19 and the work demands increasing, given their impactful role within their communities, there's a critical need to assess occupational fatigue, especially in community pharmacists. And so we have all these concepts floating around. We have fatigue and capacity, demand, safety, and of course our pharmacists. Let's not forget all of these other sub-themes that we're going off of, like workload and the patient. And so to try and make sense of it all, I utilized a conceptual framework grounded in human factors and a human factors approach. So human factors is the study of how people interact with their environment, specifically in our case, their work environment. And I used the Systems Engineering Initiative for Patient Safety, or SEEPS framework, developed by Dr. Pascal Carrion and others here at the University of Wisconsin-Madison. And within this framework, you can see there's three big key ideas. They're kind of noted in the boxes along the top. There's the structure, also known as the work system. There's the process, and there's the outcomes. The structure or the work system has at its center the human, hence the human factors approach. And in our case, that human is the person or the pharmacist. The pharmacist does their work by completing tasks, using tools and other resources, engaging in their organization or working within their organization's culture and policies. They work within a physical space or a physical environment, and they're also influenced by external factors, things like COVID-19 that are beyond their control. Pharmacists work within this structure of their work system to actually conduct patient care. And then ultimately, that can lead to outcomes such as occupational fatigue. And finally, fatigue can lead to further outcomes, distal outcomes down the line, such as patient safety issues, turnover, job satisfaction, organizational outcomes like we talked about, and reduced quality. Ultimately, the SEATS framework helps us to conceptualize how we can take a human factors and systems-based approach to understand this problem of occupational fatigue in community pharmacists, which led me to three research questions that we're going to talk about today. First, are Wisconsin community pharmacists experiencing occupational fatigue? Second, if they are, what factors facilitate fatigue, meaning cause or lead to fatigue? What factors hinder fatigue, meaning help to prevent fatigue? And finally, what are the consequences of occupational fatigue in Wisconsin community pharmacists? We know it's bad in other professions, but what does it mean for these crucial and accessible healthcare professionals? So these are our three questions that we'll hope to answer in our short time together today. So to conduct this study, I used a convergent mixed methods approach where quantitative and qualitative forms of data were collected and analyzed concurrently at the same time. After the data was analyzed, the results from these two sources were compared to generate our final interpretation and conclusion. I was interested in studying occupational fatigue in community pharmacists currently practicing in Wisconsin. That meant that my exclusion criteria were folks who were not pharmacists, like technicians or interns, those who were not practicing in a community pharmacy, settings like hospitals or doctor's offices, those who were not practicing in Wisconsin, or if they participated in a small pilot we did with 20 community pharmacists. Subjects were identified based on their voluntary enrollment in ProRx, which is Wisconsin's pharmacist practice-based research network, and recruited via an email newsletter. The ultimate goal was to recruit 60 community pharmacists to participate. I was interested in determining whether or not pharmacists were experiencing fatigue. And there are a couple of different ways that you can measure fatigue, but specifically, I chose to use subjective measures, things like surveys and interviews that get at the pharmacist's experience, and biomathematical modeling to answer my questions. So the first subjective fatigue measure was a survey that I developed as part of my master's thesis back in 2018. And as part of the study, I developed and pre-tested a survey that aimed to capture how often pharmacist-related experiences occurred over a 2-week period. I then administered the survey and conducted an exploratory factor analysis of the findings on 115 Wisconsin pharmacists. The analysis identified a statistically significant model with 2 fatigue factors. We had physical fatigue, things like feeling your energy decrease and feeling tired, as well as mental or emotional fatigue, so things like having trouble thinking clearly or forgetting whether or not you had completed a task. And this is what the primary instrument looks like. You have fatigue statements and items on the left, and then a 5-point Likert scale along the top that asks participants to rate how often these events occurred. So none of the days that you worked, less than half of the days that you worked, half the days you worked, more than half the days you worked, or all of the days that you worked. The other subjective method that I used was a semi-structured interviews with pharmacists. The interviews asked pharmacists and participants questions about changes or feelings that they noticed over the course of the workday. It was deliberate not to use the word fatigue until the participant mentioned it because I wanted them to define what that meant for themselves. I asked them about things at work or at home that facilitated these feelings or also hindered these feelings and their impact. I probed specifically on the SEAP's work system components, things like tools and technology or specific tasks and when available, I also showed them their other fatigue data to help kind of get their reaction and response to their other findings. Finally, for my biomathematical modeling, I used the Fatigue Science Ready Band, which uses a model originally developed by the US Army to try and predict fatigue in warfighters. And they follow a model of input, process, and output. So put another way, something collects and inputs the data, and the data is analyzed through a process and then results in various outputs. The inputs was the Fatigue Science and Ready devices that collect sleep data and circadian factors. So that's where the wearable devices like the Ready Band comes in. So you can see a picture of the Ready Band on the screen. Looks a lot like a Fitbit or your regular smart or active watch, and it does have watch functionality. It does work as a watch sometimes, but the watch actually houses some pretty interesting tech called actigraphy. And actigraphy is really just a fancy word for tracking movement. And so the Ready Band contains a sensor called an accelerometer that captures 16 measurements per second to determine your wrist's movement through space. Specifically, the device uses wrist movement to identify when someone is asleep or awake, their sleep quantity, and other times about how often they wake up in the middle of the night. And then they do all of this by following the assumption that someone who's awake and up in, out and about giving a presentation is more awake and is moving more than someone who's lying in bed and still awake, who's moving more than someone who's lying in bed and asleep. So next up is the process, which in this case is fatigue science biomathematical model called SAFTI, or the Sleep Actigraphy Fatigue Task and Effectiveness Model. The model is fairly complex, but suffice it to say that it uses all of those inputs and then they do math to create an output, which is their fatigue prediction, which they explain as a function of effectiveness. And they call this value a Ready score. So you can see there's the Ready Band, the Ready score, the Ready devices. But this number is essentially a calculated index of a person's effectiveness on a 0 to 100 unipolar scale. So the closer to 0, the less effective you are, and therefore maybe the more fatigued you are. And then the closer to 100, the more effective you are and kind of the less fatigued. And so it's a continuous range, but there are categorical zones as well. And so this fatigue science Ready Band also uses this Ready score to make predictions about a person's reaction time. They conducted studies to compare Ready scores to people who had varying blood alcohol concentrations. And so they try and make connections between how well a person would perform compared to someone with different BAC levels. And then they also make predictions based on a person's risk for accidents or serious error. So just as a reminder, this biomathematical model only uses movement and sleep data. And so it's only telling us about one aspect of fatigue, sleepiness, maybe, or tiredness, and might not portray the whole picture. So, and additionally, the fatigue science Ready Band provides data for all the time that a person is awake. So it's not just while they're at work, it's the whole span of while they're awake. So we have to be careful about the claims that we can make regarding effectiveness or risk for error overall, beyond just when a pharmacist is behind the bench. So just to give you a quick view of what these outputs look like for a graduate student. So before jumping into our pharmacist, you can see this green kind of squiggly line here. That's me. That's my effectiveness or my Ready score plotted over time. My values ranged between 80 to 100 with a little dip in the middle here. This was back in 2019. Here's my data aggregated by the day. You can see my sleep quantity, sleep quality, awakenings, and how long I was awake. You can see on the night of the 28th, I got 4 hours of sleep, which then led to a Ready score of the 80s the following day. It also shows me data down to the minute level. There's my 4 hours of sleep. And then you can see these are the zones of effectiveness and predictions. And so this was the kind of data that we were getting for all of our pharmacists. You can see here at the top with a Ready score between 90 to 100, you're considered in the high effectiveness zone. Your reaction time is only slowed by 5%. You're predicted to perform the same as someone with a blood alcohol concentration of 0 and at a very low risk for serious accident or error. You can see I spent 71% of my total time kind of in this zone, which is in the green here. And then you can step through, there's reduced zones and low effectiveness zones as well. So that's kind of the broad overview of the data that we were collecting. The quantitative data was analyzed in addition to the SAFTI biomathematical model via descriptive statistics and by analysis of variance, or ANOVA, testing to compare fatigue results across different practice settings. I also tended to use some multiple linear regression modeling to identify associations between various factors. Then I used R and RStudio and Microsoft Excel to complete this quantitative analysis. The qualitative interview transcripts were analyzed using deductive content analysis, and then I pre-identified potential codes using the SEEP's work system components and also added inductive codes as necessary to kind of fit the data. Finally, for the integration and comparison of the mixed methods, I utilized the joints display to help me conceptualize different configurations of the quantitative and qualitative data to help identify major themes. So in total, we had 40 participants complete the study and wear the Ready Band, but only 39 who filled out the demographics form. So you can see our participants were on average about 36 years old, 2/3 identified as women. Most participants were white and worked as a pharmacist at their current pharmacy for 3 years. Most of the pharmacists consumed on average about 2 servings of caffeine a day. Most participants worked in either a national chain, such as your Walgreens, your CVS's, or independent pharmacies, such as Hometown or Hyatt. And then the remaining participants worked in a different community pharmacy setting, such as a grocery store. On a typical workday, most pharmacies had 2 full-time pharmacists staffing, and then they also had 3.5 full-time technicians, interns, or other support staff working with them as well. The participants' pharmacies filled an average of 400 prescriptions a day, but that volume ranged between 17 prescriptions at an independent pharmacy to 1,500 at a chain pharmacy. And then during the 2-week data collection period, most pharmacists reported working 10 out of the 14 days. And pharmacists reported working about 9-hour-long shifts on average, and 70% of the pharmacists stated that they received some sort of scheduled break within the workday. The Ready Band told us that our pharmacist participants got about 6.5 hours of sleep each night, and usually woke up about once every 2 hours. The average Ready score was right around 89 to 91. The mean was 89.5 and the median was 91, so we're kind of right on that high to reduced effectiveness zone kind of range. But 63% of our pharmacists had an average Ready score of at least 90, so that's in that kind of like high effectiveness zone cutoff. An ANOVA test identified that there was no statistical difference based on pharmacy setting, so whether chain, independent, or other, there weren't really any differences. And our data didn't necessarily meet the assumptions necessary to truly use linear regression, but it pointed us in the direction that there might be some associations between Ready scores and the number of individuals living in the house. So Ready scores tended to be lower for folks with children under the age of 18 in the home, and higher, meaning more effective, for folks that had more than one adult over the age of 18 in the house. The regression did not indicate any association between work characteristics such as prescription volume or staffing. When we break down the data into these Ready score zones of effectiveness, you can see here in the green that our participants spent about 58% of their time on average in this high effectiveness zone, where it was predicted that their reaction time would be slowed 0 to 5%. It performed the same as someone who had a blood alcohol concentration of 0 and with a very low risk for serious accident or error. Again, this was all the time they were awake, not just while they were at work. Participants spent about 38% of their time in this reduced effectiveness zone with a decreased reaction time between 18 to 34% and a low to elevated risk for serious accident or error. And finally, participants spent about 3% of their time awake in this low effectiveness zone. So this zone is associated with a 55 to 100% slowing of reaction time, performing the same as someone who's legally intoxicated in the state of Wisconsin, and a high or very high risk for serious accident or errors. So I know we're not technically in the discussion portion yet, but just to help put this value into context, a study by McCormick et al. In 2017 of 27 medical residents, these medical residents spent 27% of their time in this low effectiveness zone. You figure they're medical residents, they're working overnight shifts or long extended hours, but maybe to help contextualize it a little bit. So our fatigue science Ready Band indicates that maybe our community pharmacists are experiencing some sort of occupational fatigue. But we can further attempt to answer our question using our pharmacist fatigue instrument and survey data. So remember, pharmacists were asked to respond to several Likert scale questions and rate the frequency at which these kind of fatigue-related events occurred. When asked how many days did you feel that your energy decreased over the course of the day, 5% said none of the days that you worked, 20% said less than half of the days you worked, adding up to 25%. That's the number on the left, the far left there. About 8% were in the middle, saying that they felt their energy decrease on half of the days that they worked. 43% said that they felt this way more than half of the days that they worked. And then another 25% said that they felt their energy decreased on every day that they worked, adding up to the 68%, stating that they felt that their energy decreased on more than half the days they worked on the right-hand side there. So kind of the green or the bluish zone. So you can kind of see how these visualizations work. The more green, the more blue, the more pharmacists reported these events occurring. When asked how often pharmacists felt more tired later in the day than at the beginning of the day, 23% said less than half or none of the days. 10% said about half the days they worked, and then 67% said about more than half or all of the days that they worked. Moving along a little bit faster, 42% of the pharmacists said that they felt pain or discomfort anywhere in their body more than half of or all the days that they worked. Over 50% of the pharmacists said that they felt like they could not keep up with their work more than half to all of the days that they worked. 50% said that they had times where they felt that they could not go above and beyond their standard of patient care more than half to all of the days that they worked. And 30% said that they found it necessary to take shortcuts when providing patient care more than half to all of the days that they worked. Of that, 18% of pharmacists reported that they needed to take shortcuts every single day that they worked. So considering our Ready Band and our subjective survey results together, we can say that yes, Wisconsin community pharmacists are experiencing occupational fatigue of some sort. But perhaps more interestingly, why? Why? What personal or work system factors facilitate or hinder this occupational fatigue? The SEEPS framework is helpful to organize and describe these components of the work system. There's the person, the task, the tools and technology, the organization, physical environment, and the external environment. Being in graduate school for 5 years, I think I could probably recite SEEPS in my sleep, as many in the room, but so pharmacists identified personal factors that contributed to their experience of fatigue, including prior injuries as well as pregnancy status. We actually had three pharmacists who were pregnant at the time of data collection. Similarly, they identified things that help to deal with or prevent fatigue, such as being younger in age, caffeine, past experiences that help put their fatigue into perspective, and prioritizing well-being while at work and a generally positive outlook. There were also factors that were variable and can kind of both facilitate or hinder fatigue, such as their life outside of work or having an outgoing personality. In Pharmacist 12 Exemplars quote, they talked about how their children are helpful to cope with the feelings of fatigue, but if their kids don't get a good night's sleep at night, that can impact their feelings of fatigue the following day. As a reminder, this kind of coincides with our associations we found with our Ready Band results, where the lower number or your lower Ready Band score, Ready score associated with the number of minors in the household. And that could be due to caregiving responsibilities or just children that keep you up in the middle of the night. Regarding pharmacist tasks, participants identified that the volume of tasks, the type of tasks, and the need for multitasking significantly contributed to their fatigue. Pharmacists also said that doing tasks that they enjoyed, however, helped them or hindered fatigue. For some, this was providing vaccines or having a meaningful interaction with a patient, but sometimes it became complicated. When they were faced with so many other tasks that they had to do and other demands, they couldn't really spend as much time doing things that they liked doing. Pharmacist 36 described the mental exhaustion they faced when having to review a lot of prescriptions before that they could even be filled. Kind of relates back to our pharmacist fatigue instrument when our pharmacist stated that they had feelings where they felt like that they could just not keep up with their work. The number one piece of technology that pharmacists identified as facilitating fatigue or kind of leading to these feelings of fatigue was their telephone, and that it was often constantly ringing. Tools that pharmacists identified that helped or hindered fatigue were comfortable shoes, playing music, wearing telephone headsets that allowed them to move about the pharmacy or multitask. One tool that numerous pharmacists mentioned in different capacities was the use of a centralized call center. So for like a large chain pharmacy, it's this center, right, that takes and kind of triages all of their phone calls for them. For some pharmacists described that it was helpful to offload tasks and the massive amount of phone calls that they received, but other pharmacists described how it was often problematic. Like pharmacist 5, who said that the call center sounds like a good idea in theory, but it's not, because the call center doesn't know that they're behind on their prescription promise times and tells the patients unrealistic times, and then the patients show up and are upset. The next SEEPS component is the organization, which encompasses culture as well as organizational policies and procedures. A major organizational contributor that pharmacists identified facilitating fatigue was staffing. So whether that was lack of technician staffing or long pharmacist hours or numerous shifts in a row, pharmacists mentioned the struggles of trying to keep up with their work given the staffing resources that they had. They described factors that help to prevent fatigue, such as coming in early and support from their organizational leadership, as well as support from their coworkers. The topic of breaks was mentioned as both a facilitator and a hindrance to fatigue, and it often depended on whether the pharmacist was actually able to take a break or whether they were able to utilize their break as a kind of true break. Pharmacist 1 stated in their quote how they technically got a 30-minute break when the pharmacy closed for lunch, but they didn't really use this time because they used it instead to listen to voicemails or to work uninterrupted. So this kind of emphasizes this value of protected work time without distractions or interruptions or noise, but that's not really the same thing as taking a restful and recuperative break where you get to eat for lunch. The main physical environment factor mentioned was this requirement and kind of thought that they needed to stand throughout the day. Numerous pharmacists mentioned how the use of stools or chairs was essentially banned without a medical excuse. Like pharmacist 11, who said that stools are highly frowned upon within the culture and that you'd better be, quote unquote, actually injured if you sit down during the day. This need to stand may be reflected in pharmacist fatigue instrument responses where 42% said that they experienced pain or discomfort some or more than half the day that they worked. And finally, many pharmacists mentioned the impact of the external environment, namely COVID-19, on their work demands and their capacity and their overall fatigue. COVID-19 increased the amount of work and tasks that they were now responsible for, from vaccines to COVID testing. Pharmacist 10 explained how the vaccines provided an extra level of crazy and how it was hard emotionally having to provide the immunizations to people who are upset about having to get vaccinated. I want to share a couple more of these themes regarding COVID-19 because I think we have a unique, horrible, but a unique opportunity to look at the impact of this global pandemic on our community pharmacists as well. So pharmacist 12 described the difficulty of administering COVID-19 tests through the drive-through, not just because they were difficult or being potentially exposed to COVID-19, but because administering and running the tests took technicians out of the pharmacy for several minutes at a time and out of the workflow. Pharmacist 5 described how community pharmacists were accessible and available and ready to provide these COVID-19 and meet their community's needs, and then the staffing left, and that wasn't as great. And finally, pharmacist 17 explained that COVID-19 is not going away, but the role for pharmacists is changing and more is being demanded of our pharmacists. In their own words, they said, I feel like the next couple of years, there may be some challenges for retail and community pharmacy to change and then adapt to those demands as well. During their interviews, pharmacists identified facilitators and hindrances across the entire work system, namely volume of tasks, this ability to sit and take breaks, staffing, and the COVID-19 pandemic. But finally, I wanted to know, what are the implications and consequences of this fatigue? The results of the semi-structured interviews illustrated outcomes falling into three main categories or three main domains: the person or the pharmacist's well-being, the patient experience and safety, and the overall organization. Pharmacists described how their fatigue impacted their home life, their stress, and even their physical health. Pharmacist 9 described how when they got home from work, they didn't want to do anything, even prepare a meal, and so their eating habits suffered. They described how their increased workload and stress impacted their patients as well, like pharmacist 10, who mentioned how their workload, volume, and stress was associated with dispensing areas that reached the patient. And others mentioned how they weren't able to just say hi or hello to their patients because they had too many other things to do. One pharmacist told me that she had started to master the art of backing away slowly when their patients were talking to her so that she could go back to the other things that she had to do. We think back to our pharmacist fatigue instrument findings that 50% who said that they were unable to go above and beyond standard patient care more than half or all of the days that they worked, and this 30% who said that they found it necessary to take shortcuts when providing patient care to more than half or all of the days that they worked. And maybe to our fatigue science ready band, and our pharmacists spent over 40% of their time in these reduced effectiveness zones with increased risk for serious accidents or errors. Now, this is all the time they're awake, not just while they're at work, but you might be able to extrapolate. Some of this time might overlap. And finally, pharmacists speculated how their fatigue would impact their organizations and the profession at large, namely in forms of decreased metrics and quality and staff turnover. Pharmacist 13 explained how all it takes is a couple of people to quit and it could be a disaster. We're talking about their technician, this mass exodus of technicians that they were experiencing. Ultimately, pharmacists identified how these feelings of occupational fatigue likely impacted their own well-being, their patients' safety and experience, and their organization. So we know that occupational fatigue exists. There are personal and work system factors that contribute to fatigue, and it has probably some negative downstream effects. So now what? What can be done to address this pharmacist occupational fatigue? Whenever I was in my interviews with pharmacists, I always tried to end on a positive note because I never wanted to leave and say, okay, here's all these bad things. Now see you later. Here's your gift card. But remember that in order to make sense of all these concepts and terms, we use a human factors approach to help us describe and conceptualize this complex concept. So we'll take a human factors and work system approach when discussing ways to mitigate fatigue and its risks and prevent fatigue as well. So these strategies are often summarized by fatigue risk management systems or fatigue risk management plans, which are systematic ways to address fatigue in the workplace. For our pharmacists, we can use a conceptual framework proposed by Stiege, Pinkenstein, and others who conduct research on fatigue in nurses here at the University of Wisconsin-Madison. And the fundamentals of this framework go back to the balance between work demands and the capacity to do the work. And fatigue often exists when there's an imbalance, right? Or our demands are heavier than our capacity to do work. So ideally, we could prevent fatigue or mitigate fatigue by balancing the scales or tipping it back even in the other direction in favor of increased capacity. It's like this, maybe, right? So first and preferred way is to reduce our work demands. So maybe we just eliminate some of this negative weight of workload. But maybe eliminating tasks isn't feasible. So maybe we offload those tasks to other trained personnel, such as technicians, who are now able to do final product verification via tech. Or it's passing off our vaccines to technicians or trained interns. In theory, freeing up time for our pharmacists that they have to do other tasks. But remember, we have to balance this between some of our pharmacists that find value in doing these tasks and they like vaccinating patients. So it's a thoughtful balance between how we can best balance out these scales while also reducing pharmacist work. But maybe reducing work demands isn't possible at all. You're telling me, nope, that's not feasible, Taylor. Another strategy might be vastly increasing our capacity to do work. Pharmacists mentioned difficulties with staffing and technicians and even pharmacist hours. So looking at ways to potentially hire and recruit and keep new employees as we approach improving capacity, right? We know that fatigue costs employers $100 billion each year. And so maybe we can use some of that money, right, by hiring new folks as well. Capacity and resources may also come in the form of organizational and leadership support. Motivation can go a long way in helping to balance the scales. Part of the SEEPS model, called the balance theory, emphasizes that positive aspects of the work system can sometimes counteract negative aspects or compensate for the overly negative aspects of the work system. So even if you're overloaded with prescriptions and COVID-19 vaccines and tasks, knowing that you have some support from your organization that prioritizes your well-being and your safe patient care can be helpful. And finally, you may say, Taylor, well, none of those strategies are possible. We can't eliminate work tasks. We can't hire new people. We just have to deal with it. And so other strategies state that, well, if we can't prevent fatigue by reducing our demands or increasing capacity, we should at least attempt to mitigate the negative effects or those downstream effects of fatigue and prevent potential patient harm. This may be having safety mechanisms in place or technology, alerts, or barcode scanning that'll help to catch these errors that slip through the cracks from reaching the patient. And finally, we can help to educate employees on personal strategies that they can use to cope with fatigue, such as sleep hygiene and caffeine and mindfulness strategies. But we have to recognize that these strategies are kind of like putting a Band-Aid on a bursting dam. It doesn't really solve the problem. It just helps to kind of cover it up. Ultimately, these fatigue risk management systems emphasize that there's a joint responsibility between the employer and the employee. You can't expect pharmacists or anyone, right, to be able to meditate their way out of excessive workload and demands. But you can expect or hope that they'll show to work well rested and ready to face the day with maybe a positive attitude. And it's the responsibility of the employer to reduce or minimize those factors that facilitate fatigue and promote factors that help or hinder fatigue. And ultimately, make sure that the systems are in place to keep pharmacists and their patients safe. Study needs to be considered in light of its limitations, namely the limited sample size and the convenient sampling. There's also potential for selection bias. So, individuals that were experiencing fatigue or interested in the topic signed up, but also the potential that individuals that were too fatigued to sign up didn't sign up, right? They were too fatigued for the fatigue study. So there's limitations in that regard, right? There's also limitations in generalizability beyond Wisconsin community pharmacists, just by the nature of qualitative data. But the study does have a lot of strengths. It took a systematic human factors approach to address this complex and critical problem of occupational fatigue in community pharmacists, utilized some novel wearable technology to measure fatigue and sleepiness in a unique population, combined quantitative and qualitative data and mixed methods approaches to generate potential solutions to occupational fatigue. And finally, it provided us some meaningful data and artifacts about pharmacists' work during a global pandemic. The problem existed long before COVID-19. I certainly proposed this project long before I even knew what COVID-19 was, but I'm grateful and honored for the opportunity to collect these stories of the pharmacists who are working on the front lines during this unprecedented and challenging time. What's next? There are some potential areas for future research. I mentioned all the different ways to measure occupational fatigue, back in the methods. So beyond what we use for the study, there's looking at performance measures, looking at reportable metrics, maybe like efficacy or error reporting, as well as asking participants to complete tasks and measuring how long it takes them as a function of fatigue. Behavioral measures, looking at things like eye drooping or the ability to stand up straight. Physiological measures, so there's looked at levels of cortisol levels in your saliva as a measure of fatigue, and so potentially doing that in pharmacists as well, right? But this problem of occupational fatigue isn't just in community pharmacists. So I think it would be neat to look at occupational fatigue in other settings, such as hospital or ambulatory care pharmacies, looking at the ready bands or giving the ready bands to pharmacists who work overnight shifts or in long hospitals staffing for 24-hour periods where their sleep might be likely to be disrupted. And also I'd like to look at pharmacist technicians and interns to see how team dynamics play a role in fatigue and fatigue risk management factors as well. And I mean, obviously, we can also look at interventions aimed at reducing fatigue and improving pharmacist well-being and safety. But as I always joke, I get job security, right? By finding the problem and then just delaying figuring out the solutions until later. So overall, this study provides plenty of data to support this fourth tenet of the quadruple aim. The quadruple aim identifies healthcare and healthcare professional well-being as a cornerstone to efficient and quality patient care. Pharmacists identified patient safety concerns when they were fatigued and when their work demands exceeded their capacity and resources. Fatigue alludes to problems and failures and inefficiencies within the healthcare work systems is much more complex than simply one individual's experience with sleepiness. Fatigue, especially pharmacist fatigue, is critical and complex and will require complex solutions. Ultimately, we owe it to our pharmacists and to their patients to ensure that they have the best prescription for safety. So, and with that, I'd like to acknowledge the numerous funders for this project, including the Saunders Research Center, their dissertation grant, the Agency for Healthcare Research and Quality, our 36th Dissertator grant, Midwest Center for Occupational Health and Safety, Education and Research Center, which funded my initial pilot study with fatigue science ready bands, and UW-Madison CTSA and the Pharmacy Society of Wisconsin, which supports ProRx for use for recruitment. So I wanted to say an immense thank you to my advisor, Michelle Chewy, my fabulous pharmacist fatigue dissertation committee, Jay Ford, Dave Mott, Ed Portillo, and Lindsay Steege, the Systems Approach to Medication Safety, the SAMS Lab, and their fantastic members for helping me in preparing for this and listening to me bantering on about fatigue forever, PSW and ProRx for their recruitment, the incredible pharmacists, both that I've had the opportunity to work with throughout the years and also those who participated, the incredible Kristen Houston and Tyler Dorr, who without which you wouldn't know that this event was occurring. I wouldn't have purchased the ready bands and were so crucial. And then obviously to my HSRP, the faculty and students who were so helpful and supportive in my community as well. And with that, I'd love to hear your thoughts and questions in the remaining 20 minutes or so that we have left. Thank you. I made it. I know Tyler's going to be moderating the chat as well. Yeah.
So I have a question just out of curiosity. In the semi-structured interviews, you mentioned that you did not mention fatigue to see how pharmacists would describe it themselves. How did they describe fatigue?
Yeah, that's a great question. So for those on Zoom, it was a question regarding in the semi-structured interviews, I specifically didn't use the word fatigue and allowed pharmacists to describe it themselves. And the question was, how did pharmacists describe it? It was interesting kind of depending on the scenario. So some pharmacists described it as like a fuzzy feeling, trying to get at this idea of having like trouble thinking clearly. Some mentioned that they were having, they noticed they were having pain, especially leg pain or headaches that would occur over the course of the day, dependent too on their nutrition and whether or not they were able to drink water. It was interesting. Some pharmacists described it as like an autopilot. They like compared it a lot to that feeling when you're like driving home and then you don't realize that you got home. But they would have that while they were at work, where they would be checking prescriptions and they would have to check it a bunch of times over again. So they didn't use explicit words more so, but kind of describing phrases or scenarios in which they kind of noticed it. Yeah.
Super presentation, outstanding work. Really enjoyed, very clear description. I have a comment and a question. The comment is I am skeptical that a triaxial accelerometer can measure fatigue.
Yeah.
To be deeply asleep and don't do it in that line movement, moving around in the dream, that you could be sitting in bed getting an extremely clear thought and energy and not be moving at all, and then everything in between. So you didn't try to validate those. No. Somebody else did that before. I think it's a measure that could be really well and sleep somewhere. My question for you is on the realm between fatigue and burnout. So in the medical world, there's lots and lots of stuff, and it usually talks about burnout, less fatigue. Is fatigue something you go to sleep and wake up rested, or is there a chronic thing? Or what are your thoughts about fatigue?
Yeah, thank you, Dr. Berry. Yeah, so for those on Zoom, there was a comment about kind of fatigue science ability to truly measure fatigue, as opposed to kind of getting it some of the ways that you could most fool the bands. But there was a question about kind of the spectrum between fatigue and burnout. And so to kind of go back to that, because that's a fantastic question. So within the literature, they are separate components more so. So occupational fatigue is kind of this, again, a construct about the body's need for rest. And burnout has been described a lot in the literature of kind of this Moshlock burnout inventory of three domains. You have lack of personal accomplishment, depersonalization, and emotional exhaustion are kind of the big three. And so when I think of them and when I like to think about them, I might step over here just for a hot second, right? But I kind of see fatigue as more of the proximal outcome, right? It's immediate, and fatigue can range between acute and chronic. So acute fatigue meaning you can take a 15-minute break and you're like well rested and you're ready to go, versus chronic where you need a week-long vacation. When we think about burnout, it's often more so of a chronic mismatch between the job and the employee that's much more long-standing. It's hard to go on a vacation and come back like ready to go if you're if you're experiencing burnout. Sometimes you face more dread coming back to the job than whenever than a vacation would allow. So a lot of the literature states that fatigue is more of a proximal outcome, and then further down the line comes burnout as a potential distal outcome. I didn't do any kind of like mediating or moderating studies in this sense. I did measure for burnout, but looking at it more so of kind of burnout as this chronic, long-standing mismatch between the person and the job that they're able to do, as opposed to fatigue, which is more of an acute chronic range. But thanks.
There's a question in the chat.
Yeah.
Jess Fairbanks said the ready band results mostly high functioning, but interviews tell a different story. What could cause the disconnect?
Yeah, thank you so much. So there was a question, thanks Jess, so what might cause the disconnect between individuals that, their ready band shows that they might be in the highly effectiveness zone, but their interviews and kind of their subjective findings tell a different story. And I think a lot of that goes back to almost what Dr. Barrett was mentioning about, the ready bands capture one aspect with regards to sleep and sleepiness. And so that tells maybe one part of the story with regards to fatigue, but I don't know that the ready bands and the wearable devices in general are super helpful at being able to measure. I had a really high work demand and I had 500 prescriptions and all 3 technicians called off. There is a little bit of an area for this kind of feedback loop on the bottom there. It's called rumination, right? Where our fatigue that we experience throughout the day, right? We have rumination, which is this anxiety in anticipation of our work demands. And so sometimes you can maybe imagine how like you had a really stressful day at work and then you go home and you think about it all night, right? And so that prevents you from getting a good night's sleep. And then when you don't have a good night's sleep, you're not ready to face the day, and then you have kind of more fatigue afterwards. But I think the kind of disconnect between the two is this kind of idea of the ready bands captured sleep and the ability to, were our pharmacists getting good night's sleep, which doesn't necessarily coincide with their true work or work volume that they're experiencing. All the more highlighting the need for mixed method studies, looking at both, or not using ready bands in the future, but they're kind of cool. But thank you. Thanks, Jeff. Yes.
So this is great work. I mean, oh my goodness. It's so impactful because these are things that I think culturally we don't always talk about this stuff. Because I feel like there's this culture in the workplace to keep going, put your head down, you gotta get it done. And if we're complaining, we're bringing things up, well, why are you not getting your work done? With that in mind, I could be totally off there.
Yeah.
So my question is, when you were doing these interviews with pharmacists, like I would imagine that might have been one of the few times where they were sitting down with someone and actually having this like time dedicated to discussing their challenges. And I'm just wondering what you perceive as how the pharmacists were feeling about that, how they reacted to that discussion. Was it welcome? Was it hesitant? Like, because that's a whole other thing, is getting good accurate information. And yeah, just one of your thoughts.
Yeah. Thanks, Dr. Portillo. So to kind of rehash kind of the comment and the question along there was fatigue and work well-being in general can sometimes be like this taboo topic of like, well, we don't talk about it, like, and this idea that if you're complaining, you could be working. And so the question was around, were pharmacists receptive to talking about this? Any just kind of how those conversations went, more or less, and kind of getting at some of your questions there. I think I'm very grateful that the pharmacists that I talked to, and maybe this is leading a little bit into the selection bias, but the pharmacists that I talked to were very genuine in their experiences, and making sure, setting everything up in the interviews to make sure that they felt safe and that they were in a safe experience, safe environment. They weren't like in the middle of work. Like I didn't call them in the middle of the workday where they were chatting about all of their terrible experiences. And so making sure that was part of it for me. And I think pharmacists were very open. Some of them talked about it, but not necessarily as much. There was this kind of feeling of accountability to others, right? That you were it was just this expectation, especially for young pharmacists, that they were just supposed to work. This is what being a community pharmacist was, that they were supposed to work these long hours, and then eventually when they earned their keep, right, they could stop doing that. But I think definitely it was this, I think it varied based on kind of perceptions based on age. But I think too, not to discredit, there's a movement going on right now within community, within all pharmacy, but within community pharmacy in general. Wait, let me jump through some of my additional slides, right? And I don't know if folks in the room are common, but it's this like viral hashtag that's going around on social media. It's called "Pizza is not working," and it's kind of this movement where community pharmacists in particular are kind of calling out like their low staffing levels, right? So there's this a meme for those that are well versed in memes. It says, "In case of low staffing, break glass," and it's like a picture of a piece of pizza, right? So I think some pharmacists were fueled by that, and they were saying like, "Oh, are you on this Facebook group? Like, I love that group. They talk a lot about all these different things." So I think I think it's moving conversations in the right direction where people are feeling more comfortable talking about it. I think a lot of pharmacists were just happy to have an outlet and to get paid. So pharmacists did receive a $100 Amazon gift card at the conclusion. So to get paid to kind of vent their feelings, sometimes 30 minutes wasn't enough. And they would send me like long emails after the fact. So I think it varied, and some pharmacists were very happy and were happy to share their experiences with us.
The fact that you probably did a great service to it.
Yeah, I think that was. Yeah, I think that was the challenge too. And I had a lot of meetings with Michelle of like, oh no, this pharmacist emailed me like this very long email about like their complaints about the work system. Like, well, how do I, as a student, one, right, but as like a fellow pharmacist, I have a lot of empathy for these people that, are telling you these things. And I think that was part of, I tried to make a joke of it, right? But truly in these interviews, I would sit there and like these pharmacists were like pouring their hearts out to me. And so I would always try and end on at least a somewhat positive note, asking them, what makes it worth it? How do you find value in your work, and trying to get at some of those positive factors? Because if not, I would be blamed for a mass exodus of more pharmacists from the community pharmacist workforce. But yeah, that's a great question and a great one. Yeah, Aaron. Thank you.
Really great linear narrative and implications from the in your description of what can be done to help it, and especially organizations responses to work demand. Given all the literature that you look at, your real life work experience in pharmacy, using your human prognostic powers, what is the likelihood that organizations will actually attempt to improve and advance capacity, say, in the next 5 years?
Yeah. Hitting with a tough question. So Dr. Gilson asked, what is looking at my magic crystal ball, what is the likelihood, right, that organizations will take these steps to either improve capacity or reduce demands within the next 5 years? I think it can go both ways. I think we've been seeing really positive steps forward, at least recently. So while I was conducting this study, both two chain pharmacies rolled out mandatory, where pharmacies were closing for lunch breaks, right? And that was just kind of within this study, right? That now these pharmacies were closing down for 30 minutes for lunch breaks. I think that's a positive step forward, and right, that comes with pros and cons as well. I didn't include it in here, but there was this quote from the patient, from a pharmacist who was saying about how mad their patients were that they were closing for lunch, right? So I think that there's some good momentum in that regards as well. I think especially some of it is state driven. So especially in Wisconsin, there's kind of, there's a lot of movement from organizations like the Pharmacy Society of Wisconsin that are kind of pushing forward for things like technician or tech and other like technician delegated vaccines. And so I think that that's all a good step. I think that there will likely be movement, at least in regards to offloading tasks. Not necessarily, do I think that it's necessarily from a caring about pharmacists' well-being prognostic? Maybe, but I think some of it might be related to efficiency, right? So the implication of call centers, you know, the ability to vaccinate more people if you have more vaccinators and hiring more staff, right? I think some of it will be monetarily driven in the next few years, but I'm also kind of hopeful. I think a lot of times the big organizations get involved whenever patients make, you know, whenever they see that there's a true impact for patient harm. So a couple years ago in Chicago, one of the Chicago Tribune did their own sort of study where they sent in kind of like standard fake patients essentially to see whether or not community pharmacists were catching errors that were occurring. And they found that a vast majority of these community pharmacists were not catching errors, right? And so that came out in the news, right? That was like a large news source in Chicago. And then all of the organizations were springing into action, like, oh my gosh, we're gonna increase our staff, we're gonna do all of these things. So I think it's whenever the patient becomes kind of becomes into the picture that organizations are more tied to move. I would like to say that I think pharmacy will definitely be changing in the next 5 years because especially seeing the mass exodus of technicians, there's just a lot of movement in this space that I will be interested to keep my eye on. Do I think that they're going to hire a whole bunch of new staff and reduce work demands? Not really. I can be optimistic, but I think we're moving in a somewhat good space. Sorry, my long answer to your short question. But yeah.
Lots of questions rolling in the chat. Dr. Abraham said, did pharmacists in your interview allude to medication safety errors that ensued due to occupational fatigue? And how might this be studied in the future?
Yeah, great question. Thank you, Dr. Abraham. So the question was, did pharmacists allude to medication errors that occurred due to occupational fatigue and how might that be studied? So very vaguely, I would ask kind of a very broad question of, you know, do these feelings that you experience over the course of the day, do they lead you to performing maybe not as well as you would like? Or have you noticed any downstream effects on your patients? And that's when some of the pharmacists would share that, you know, there was one instance where a pharmacist said that, you know, they were running around and it came out after the fact that they had made several medication errors that had actually gotten to the patient. So in that clear example, yes, they did. Some pharmacists were cognizant of the fact that they were more worried about the medication errors that they didn't know about. That they assumed that it was happening, especially on these cases where they were running on autopilot. They're like, I'm sure I made some mistakes, but it either hasn't come out yet or I don't know about it. And so I think that both alludes to that, yes, pharmacists, the challenge of studying this, right? Like, yes, pharmacists are aware of it, but part of the challenge is that you don't know that these errors are taking place. And especially if you're not always, there's a lot of research on that folks that are fatigued don't necessarily know they're fatigued in the moment. It's more so after the fact. And so it can be hard to kind of study like this correlational relationship between, are you fatigued right now and did you make a mistake right now, especially because a lot of them are very retrospective. There's been some studies on the nurses using log books, right, where you have an individual like have a daily diary and they said, you know, this is how I felt at the end of this work day today, and then they keep track of whether or not there were near misses, whether any errors actually occurred. And so using that as a way to study, you know, specifically medication safety. There's also, and this is probably more than you had asked for, Dr. Abraham, but there's also this kind of like liability concern, right? This like weird space of, you know, if organizations know that their employees are fatigued and then it comes out that these errors take place, well, whose fault is it, right? And I mean, in an era where like blame and shame society is not what we should be working for, right? But there's always someone wants to point fingers at. This idea of, you know, is it the organization who allowed their employee to come to work? Is it they didn't have safety metrics in place? Is it the employee that made the error, even though they were fatigued due to work demands, right? There's a lot of messiness within that. And so some organizations may not be willing to partner with, you know, to look at errors specifically in those instances. But I think trying as best as possible to look at, you know, it's a difficult question of trying to, I'm looking at the puck. I don't know if you can see me. I'm looking at the puck trying to talk to you, Dr. Abraham. But I think it's a difficult question of trying to kind of correlate these two metrics together and trying to be as subjective as possible in this very kind of fuzzy and subjective space. Thank you for your question. Is there more questions in the chat?
There is. Banyan said, did you notice any difference in themes between pharmacists working in independent pharmacies versus chain pharmacies?
Yeah, great question. So a question from Banyan was, did I notice any differences in the interviews or just in general between pharmacists working in independent versus chain pharmacies? More so, the volume was definitely different. So there were very high volume independent pharmacies as well as some low volume chain pharmacies. But I would say the biggest area that I noticed the biggest difference was in this idea of organizational support. And I think part of that comes down to in independent pharmacies, you're kind of closer. The hierarchy is a little bit thinner, right? You have less rungs until you get to the top. And so it was easier for organizational support to come through. And a lot of individuals felt more support from their organization, even whenever they were doing high workload and trying to meet excessive demands. So one of the pharmacists who actually reported making a medication error actually worked in an independent pharmacy. And they commented on about how their boss essentially and the owner of the pharmacy was saying, oh my gosh, yes, I would have made that exact same mistake. What can we do to improve that in the future, right? Is that getting you more staff? What can we do? And so I think that's kind of some of the biggest difference is in finding in that organizational support. Whereas in community pharmacies, or retail pharmacies, it can be easier, can be more separation and less kind of locus of control between what can actually be changed. Recognizing time, it is now 9:01. We're officially over. But I'm happy to stick around before we make everyone leave. But if anyone has any additional questions, or let me put my contact information back up on the slide. Folks want to send me additional questions my way. One more question? Okay.
One more in the chat from Alyssa. She said, congratulations, Taylor. Such interesting work, especially during such a time of intense change for community practitioners. Have you considered or already shared your work with pharmacy employers and or national pharmacy associations, working groups on workforce wellness?
Yeah, thank you so very much. Yeah, so that was a question almost on kind of the dissemination of the findings specifically to pharmacy employers, organizations, and work groups. So yes and no, a little bit. So we've disseminated some of the findings at the American Pharmacists Association, their annual meeting. We've been able to share some of our findings there. We haven't taken this too much to specific employers and organizations aside from the few owners that I happen to know in my back pocket, right? To say like, hey, this is a problem. So we've been able to share it with some of those folks, but I think that that's definitely a great area when we think about any research in general, right? Giving it back to the people that it impacts. So I know APHA, which is the American Pharmacists Association, has a really big well-being initiative and a really big, they're really interested in looking at pharmacist well-being. Same with the Community Pharmacy Foundation has done a little bit with that. And if nothing else, the Pharmacy Society of Wisconsin, I think would be really interested in a great venue to disseminate this work too. To make sure that, if nothing else, almost to Dr. Portillo's point, to make sure that pharmacists know that they're not alone in these feelings and that it's not as taboo to talk about it as it has been. So, thanks. Thank you all. Thanks for coming. Thanks for your great questions.